Hydroxychloroquine, Plaquenil, is commonly used in the management of Sjogren syndrome, particularly for patients who experience systemic symptoms such as joint pain, fatigue, and skin manifestations. Here's a more detailed look at how it is used. Star 1. Mechanism of action. Hydroxychloroquine is an antimalarial drug with immunomodulatory effects. It works by interfering with the communication between immune cells and reducing the production of pro-inflammatory cytokines, which are chemicals that drive inflammation. This mechanism helps to control the autoimmune activity that is central to Sjogren's syndrome. 2. Effectiveness. Joint and muscle pain. Hydroxychloroquine is often prescribed for patients with Sjogren's who have inflammatory joint pain, arthralgia, or muscle pain, myalgia. Clinical studies have shown that it can help reduce pain and swelling in these areas, although the degree of benefit varies between individuals. Skin symptoms. Some patients with Sjogren's experience skin rashes or other cutaneous symptoms. Hydroxychloroquine can be effective in managing these conditions. Fatigue. Fatigue is a common and debilitating symptom in Sjogren's. While hydroxychloroquine is not a cure for fatigue, some patients report an improvement in their energy levels after starting the medication. 3. Impact on dryness, xerostomia, and xerophthalmia. Mouth and eye dryness. Hydroxychloroquine is less effective for the hallmark symptoms of Sjogren's syndrome, dry mouth, xerostomia, and dry eyes, xerophthalmia. While some patients do report modest improvements in dryness, this is not the primary benefit of the medication. 4. Use in primary versus secondary Sjogren's. Hydroxychloroquine is frequently used in primary Sjogren's syndrome, but it is also beneficial for patients with secondary Sjogren's syndrome, which is associated with other autoimmune diseases like rheumatoid arthritis or lupus. 5. Dosing. The typical dose of hydroxychloroquine for Sjogren's syndrome is 200 to 400 milligrams per day, depending on the patient's response and tolerance to the medication. 6. Monitoring and side effects. Eye health. Long-term use of hydroxychloroquine requires regular eye exams to monitor for retinal toxicity, which can be a serious side effect, although rare at standard doses. Other side effects. Most patients tolerate hydroxychloroquine well, but side effects can include gastrointestinal discomfort, skin reactions, and less commonly, changes in blood counts or liver enzymes. Regular monitoring is essential. Header 7. Long-term use. Hydroxychloroquine is generally considered safe for long-term use, and many patients with Sjogren's syndrome take it for extended periods, often in combination with other therapies to manage their symptoms. In summary, hydroxychloroquine can be an important part of the therapeutic strategy for managing systemic symptoms in Sjogren's syndrome, particularly for joint, skin, and fatigue-related symptoms, though its effect on dryness is less pronounced. Azathioprine, Imuron, is an immunosuppressive medication that is sometimes used in the management of Sjogren's syndrome, particularly in patients with more severe or systemic manifestations of the disease. Here's a detailed look at its use in Sjogren's syndrome. Number 1. Mechanism of action. Azathioprine works by inhibiting the synthesis of DNA, RNA, and proteins in immune cells, particularly lymphocytes, thereby suppressing the immune response. This helps to reduce the autoimmune activity seen in Sjogren's syndrome and other autoimmune diseases. 2. Indications in Sjogren's syndrome. Azathioprine is usually reserved for patients with more severe systemic involvement or complications that are not adequately controlled by less potent medications like hydroxychloroquine. Some situations where azathioprine might be used include severe systemic disease. In cases where Sjogren's affects internal organs such as the lungs, interstitial lung disease, kidneys, or nervous system, neuropathy. Vasculitis. Azathioprine can be used in cases of vasculitis, a complication of Sjogren's syndrome where blood vessels become inflamed. Arthritis or myositis, when patients experience severe joint inflammation or muscle inflammation that does not respond well to other treatments. Hematologic abnormalities. Some patients with Sjogren's develop blood disorders such as cytopenias, low blood cell counts. Azathioprine can help manage these issues. Hemistreshula 3 effectiveness. Systemic control. Azathioprine can help control systemic manifestations of Sjogren's syndrome by suppressing the overactive immune system, thereby reducing inflammation and preventing further organ damage. Combination therapy. It is often used in combination with corticosteroids, such as prednisone, to reduce the need for higher doses of steroids, minimizing steroid-related side effects. Hasher 4. Dosing. The typical dose of azathioprine for Sjogren's syndrome is around 1 to 3 milligrams per kilo day, but this is carefully tailored to the patient's response and tolerability. It is usually started at a low dose and gradually increased. 5. Monitoring and side effects. Blood tests, regular monitoring of blood counts, white cells, red cells, and platelets is essential, as azathioprine can cause bone marrow suppression, leading to cytopenias. Liver function. Liver function tests are also necessary, as azathioprine can affect the liver. Infections. As an immunosuppressant, azathioprine increases the risk of infections, so patients must be vigilant for signs of infection. Gastrointestinal symptoms. Nausea, vomiting, and diarrhea can occur, especially when starting the medication. Risk of malignancy. There is a slightly increased risk of certain cancers, particularly skin cancers and lymphomas, with long-term use of azathioprine, although this risk is relatively low when used appropriately. Danscheder. 6. Long-term use. Azathioprine can be used for long-term management of severe Sjogren's syndrome, but it requires regular follow-up and careful monitoring to avoid complications. 7. Alternative immunosuppressants. Other immunosuppressive agents, such as methotrexate or mycophenolate mofetil, CellCept, may also be considered in certain cases, depending on the patient's specific symptoms and response to treatment. In summary, azathioprine is a more potent immunosuppressive medication used in the management of Sjogren's syndrome, particularly for patients with severe systemic involvement or complications. While it can be effective in controlling disease progression and reducing symptoms, it requires careful monitoring due to potential side effects and risks. The newest guidelines for the management of Sjogren's syndrome, now often referred to as Sjogren disease, emphasize a holistic and personalized approach to treating this systemic autoimmune condition. Key recommendations include 1. Multidisciplinary management. It's essential that care is coordinated among various specialists, such as rheumatologists, ophthalmologists, and dentists. This is particularly important because Sjogren's affects multiple systems, including the eyes, mouth, and more. 2. Symptom management. For dryness, the first line of treatment involves topical therapies such as artificial tears or saliva substitutes. For refractory cases, immunosuppressive drops and autologous serum eye drops can be considered. 3. Systemic treatments. When systemic disease is present, treatment is tailored based on the severity, often guided by the Sjogren's Syndrome Disease Activity Index, ESA. Immunosuppressive drugs, including glucocorticoids, azathioprine, and biologics, are recommended based on organ-specific involvement. 4. Personalization and comprehensive care. The guidelines highlight the importance of addressing all aspects of a patient's well-being, from dryness to musculoskeletal pain, and the need for individualized care based on the patient's age, disease severity, and specific organ involvement. Source. These updates aim to enhance patient quality of life and ensure that care is tailored to the diverse manifestations of Sjogren disease across different age groups. 16. Source. Biologic DMARDs, disease-modifying antirheumatic drugs, are increasingly being explored in the management of Sjogren's disease, especially for patients with severe systemic manifestations that are unresponsive to conventional immunosuppressive therapies like hydroxychloroquine or azathioprine. Although the treatment of Sjogren's with biologics is still evolving, certain biologics have shown promise. Key biologics in Sjogren's disease. 1. Rituximab, anti-CD20 monoclonal antibody, mechanism targets B cells, which are crucial in the autoimmune response in Sjogren's. Evidence. Rituximab has shown efficacy in improving glandular function and reducing systemic symptoms, particularly in patients with extraglandular manifestations such as arthritis, vasculitis, and neuropathy. However, results in clinical trials have been mixed, with some studies showing improvements in fatigue and salivary gland function, while others did not meet primary endpoints 15 source. Current use, often used in patients with severe systemic disease, particularly those with cryoglobulonemic vasculitis or lymphoma associated with Sjogren's disease. 2. Belimumab anti-BAFF monoclonal antibody. Mechanism inhibits B cell activating factor, BAFF, reducing B cell survival and autoantibody production. Evidence. While it has been successfully used in systemic lupus erythematosus SLE, data on its efficacy in Sjogren's are more limited. Preliminary studies suggest some benefit in reducing autoantibody levels and improving systemic symptoms, but larger trials are needed. 16 source. 3. Abatacept, CTLA4 mechanism, modulates T cell activation by interfering with co-stimulation, reducing autoimmune activity. Evidence. Abatacept has shown potential benefits in reducing systemic disease activity in Sjogren's, particularly in patients with high disease activity scores. However, more robust data are required before it can be recommended as standard therapy. Fifth source. 4. Tocilizumab, anti-IL-6 receptor antibody. Mechanism blocks IL-6, a cytokine involved in inflammation and autoimmunity. Evidence. Tocilizumab has been studied for its role in treating systemic manifestations of Sjogren's disease, particularly in patients with inflammatory arthritis and systemic involvement. Preliminary studies have shown some benefit, but more research is needed. 16 source. Challenges and future directions. Heterogeneity of disease. One of the challenges with biologics in Sjogren's disease is the heterogeneity of symptoms, making it difficult to predict which patients will respond to specific biologics. Ongoing research. Clinical trials are ongoing to better understand the role of biologics in Sjogren's disease. Newer biologics targeting specific cytokines and immune pathways are being evaluated for their efficacy and safety. In conclusion, biologic DMARDs offer a promising option for patients with Sjogren's disease, particularly those with systemic involvement unresponsive to conventional treatments. However, further studies are needed to establish their efficacy and identify which patients will benefit the most from these therapies. 15 source. Targeted synthetic DMARDs, TS-DMARDs, are a newer class of medications that specifically inhibit certain molecules or pathways involved in the autoimmune process. Although most TS-DMARDs have been developed and are primarily used for other autoimmune diseases, such as rheumatoid arthritis, some are being explored for their potential in managing Sjogren's disease. Here's a look at some of the TS-DMARDs being investigated. 1. Janus kinase, JAK inhibitors. Mechanism. JAK inhibitors block the activity of Janus kinase enzymes, which play a critical role in signaling pathways for cytokines that drive inflammation and autoimmunity. Examples: tofacitinib, Xeljanz, baricitinib, Olumiant, and upadacitinib, Rinvoq. Evidence: early studies have suggested that JAK inhibitors may have a role in reducing systemic inflammation and improving symptoms in Sjogren's syndrome, particularly in patients with severe systemic involvement. However, more robust clinical trials are needed to confirm their efficacy in Sjogren's. 16 source. 2. Spleen tyrosine kinase, SYK inhibitors. Mechanism: SYK inhibitors target signaling pathways involved in B cell receptor signaling, which is important in the pathogenesis of Sjogren's disease. Example: fostamatinib. Evidence: while research is still in the early stages, SYK inhibitors are being explored as a potential treatment option for autoimmune conditions, including Sjogren's disease. Their ability to modulate B cell activity could be particularly relevant given the role of B cells in Sjogren's pathology. Bruton's tyrosine kinase BTK inhibitors. Mechanism: BTK inhibitors block Bruton's tyrosine kinase, a key molecule in B cell activation and function. Example: ibrutinib and acalabrutinib. Evidence: given the central role of B cells in Sjogren's disease, BTK inhibitors are being studied for their potential to modulate B cell activity and reduce autoimmune responses. Early data from clinical trials suggest that BTK inhibitors could be promising for systemic involvement, but larger studies are needed. 16 source. PASH4, phosphodiesterase 4, PDE4 inhibitors. Mechanism: PDE4 inhibitors reduce the production of inflammatory cytokines by modulating intracellular signaling pathways. Example, apremilast. Evidence. While PDE4 inhibitors are more established in conditions like psoriasis and psoriatic arthritis, they are being explored for use in Sjogren syndrome. Early trials have shown some promise in reducing systemic inflammation and improving quality of life. Challenges and considerations. Limited data. Most of the evidence for STMARDs in Sjogren's comes from small-scale studies or off-label use, meaning their role in routine clinical practice is not yet fully established. Future directions. Ongoing trials are essential to determining the efficacy and safety of these drugs in Sjogren's disease. They offer a targeted approach that could be beneficial, particularly for patients with systemic manifestations who do not respond to traditional immunosuppressants or biologics. In summary, while targeted synthetic DMARDs show potential in the management of Sjogren's disease, especially for systemic involvement, more research is needed to define their role in treatment protocols. 16 protocol source. The use of corticosteroids, steroids, in the management of Sjogren's syndrome is typically reserved for more severe cases, particularly when there is significant systemic involvement, such as vasculitis, interstitial lung disease, or severe arthritis. However, steroids are generally used for the shortest duration and at the lowest possible dose to manage symptoms due to their long-term side effects. Guidelines for steroid use. 1. Short-term use. Steroids are often used in the short term to control acute flare-ups of systemic symptoms. This could involve a higher dose, e.g., prednisone 20 to 40 milligrams daily for a limited period, typically tapering the dose over weeks to months, depending on the clinical response. Short-term steroids are effective in rapidly controlling inflammation but should be tapered as soon as possible. 2. Long-term use. Long-term steroid use is generally discouraged in Sjogren's syndrome due to the risks of chronic steroid use, which include osteoporosis, diabetes, hypertension, weight gain, and increased infection risk. If long-term steroids are necessary, the goal is to maintain the patient on the lowest effective dose, often length 7.5 milligrams of prednisone daily. Patients on long-term steroids require monitoring for side effects and may need adjunctive therapies such as calcium and vitamin D supplements or bisphosphonates to mitigate bone loss. 3. Steroid-sparing approaches. To minimize long-term steroid exposure, immunosuppressive agents like hydroxychloroquine, azathioprine, or biologics, e.g. rituximab, are often used as steroid-sparing agents. These drugs can help control systemic disease and allow for lower steroid doses or discontinuation of steroids. Individualization. The duration of steroid use in Sjogren's varies greatly depending on the severity of the disease, the response to treatment, and the presence of systemic complications. The decision to continue steroids long term should always be weighed against the potential risks, with efforts made to switch to steroid sparing agents whenever possible. 15 CNAS. Source. In summary, while corticosteroids can be an effective tool in managing Sjogren's syndrome, their use should be carefully limited and tailored to the individual's disease activity with a focus on minimizing long-term use.